Welcome to the VExUS Cosmos webinar on bedside physiology and POCUS, Doppler for venous congestion, the VExUS Score. I'm Dr. Bob Jones from Metro Health Medical Center in Cleveland, Ohio. And just as an FYI, you will be receiving clinical papers that will be sent to your email for you to download after this webinar. I just want to say we are really very excited to have such an incredible panel of POCUS and VExUS experts on this webinar. First, we have Dr. Philip Rolla, who is the ICU Chief of Service at Santa Cabrini Hospital in Montreal, Canada. He's an author on some key VExUS publications, and he's very active on social media, and you can find him on Twitter at ThinkingCC and on the web at thinkingcriticalcare.com. Next, we have Dr. Katie Wiskar, who's a clinical instructor in the Division of General Internal Medicine at UBC. And she's completed a one-year POCUS fellowship, including a 6-month critical care ultrasound fellowship at Western University in London, Ontario, under Dr. Robert Arnfield. And she has some really phenomenal POCUS videos at ubcimpocus.com, so check those out. And lastly, we have Dr. Abhilash Koratella, who you may hear that name and think, I don't know who this is, but you know him as NephroPOCUS. He is an academic nephrologist and the director of clinical imaging for nephrology at Medical College of Wisconsin. And he is extremely active and prolific on social media under the name NephroPOCUS. He's got the website nephropocus.com, as well as his account on Twitter. So again, we're very excited to have this, POCUS and VExUS, all these experts here for this webinar. And the agenda, you can see it on the screen here. It's important to note that since VExUS is an advanced topic that covers multiple areas of POCUS, it's going to be impossible to cover everything in 1 hour. So this is going to be the first in a series of webinars that VExUS Cosmos is really excited to be hosting. So why don't we go ahead and we can get started. Philip, I'll turn it over to you.
All right, thanks a lot, Robert. It's a pleasure and honor to be here with this esteemed faculty and moderator. Let me see if I can help shed some light on this. So I'm gonna talk a little bit more conceptually and try to just raise a little bit of the awareness on venous congestion and its importance. Basically, Robert's summed this up pretty much. I'm an ICU doc. I love POCUS, resuscitation, and most importantly, precision medicine. I think that's the only way forward for us. And I'm going to keep it simple with some pictures and numbers. I'm mostly used to trying to get messages across to my 3rd grade daughter, and I think that's what works the best. And this first thing, if we look at this, what's the first thing that jumps out to us? I think it's clearly the arterial side. I think that's where the focus has been for a long time. I think that's what everyone's comfortable and happy with. That's where everyone looks to maximize the delivery and all that stuff. And I'm going to argue that we need to pay a little more attention to that really light, faint blue stuff that we see on one side of it, but that is at least equally as important. And that basically has to do with fluids. And I think most doctors have this very pretty idea of fluids, that it's kind of good stuff. Sometimes, the more the better, that it's really, it's got this inherent goodness to it. So I'm going to also put up a few numbers to try and confuse everyone, but to try and bring it down to some of the concepts that I think we need to keep in mind. And when we look at fluids, what most of the time when someone's giving fluids, at least in the giving part of it, everyone's trying to think of, perfusion, and I've played this trick on so many, unwitting trainees, who start to answer seriously, and then, most people talk about perfusion, oxygen delivery, et cetera, until, I point out that the content, of oxygen in most fluids that we give is absolutely 0, or 0.03 times that funny, number. It essentially comes down to 0. So, whenever we're thinking of perfusion and all that, we're not giving anything in there. Here's oops, sorry, I don't know why that slide turned out like that. Here's another number, 6. Does that ring a bell for anyone? Well, 6 is an interesting number because that corresponds to the CVP above which the kidneys are not happy. So if you look at, we see so much fluid being given for renal failure, for perfusion and all that. But if you look at the literature of CVP and its association with renal function in patients, particularly with cardiovascular disease, and I think it's not too difficult to extrapolate it to most, we can see that if your CVP is anywhere above 6, your mortality over time isn't good. Now, you can say that that relates to inherent cardiac function, and it may be, but it's still a nice, interesting trend because people tend to think of 6 as a relatively low number. But I'm going to try to sell you on the idea that the body is made for that 0 to 3 level, and that the higher we get, it's not always, the more the better. Another number, 12. 12 is another interesting number. And if we look at some interesting microcirculatory studies, and I think there's been a dichotomy in the way we approach circulation for a long time, and we've been very much focused on the macrocirculation and less on the microcirculation. Why? Because it's hard to look at the microcirculation. You have to get funky sublingual microscopes. You have to slice people in some tissues. It's not an easy and fun thing. It's a lot easier to squeeze a major proximal artery and measure its pressure and be happy with what it shows. But the microcirculation, I would think, is fairly important too. And if you look at the microcirculation and you pick a line, in this case, this is sublingual microscopy, they could show that if your CVP is above 12, your percentage of perfused vessels is, and your mean flow rate in those vessels is actually lower. And the funny thing is, this is a common target, for actual fluid resuscitation. So basically, a lot of the things that we're suggested to do sometimes is to put people in states of venous congestion. And I'm going to stand on the line to say that I don't think that's necessarily the best idea. People have grown up with and say, that's part of, let's say sepsis resuscitation. You have to swell to get well and all that, leave a fed, leave them dead. And I think we can do a little bit better, nowadays. I think this guy's he looks more like a dentist, but I think he's from the 20s. So I think we can do a little bit better. And I was talking in 1920s. And I would argue that this is for those who haven't necessarily done a lot of ultrasound, this is, a short axis of an IVC at the hepatic vein level. And it's nice and full. And, I've heard many comments of we've well resuscitated this person. This patient has been nicely fluid loaded. And I'm going to argue that maybe that isn't such a good thing. The IVC is really the cornerstone of this because it's kind of like where everything goes in, at least from, the major part of the body, everything south of the diaphragm. And where all the splanchnic organs, drain into. And it's kind of the last stop before you get into the heart. And it kind of represents the balance between, the venous return, the right atrial pressure. So it's kind of that last train stop, that last bus stop, and we can get a lot of information from looking at it. I look at it all the time in many patients every day, and I'll base a lot of decisions on the IVC and its friends. Now, one of the friends of the IVC that ends up draining into it is the portal vein, and in the corner there I've got André Deneau. I hope this is going to keep looping. That's what I tried to make it do. And he did some seminal work, even though he wasn't the first one to look at the portal vein in venous congestion. He found in post-op hearts, which obviously have a lot of RV dysfunction, transient and chronic, that there's a strong association between portal vein pulsatility, which my colleague Abhilash will go through the various curves in a much better way than I could in the next segment. But that when pulsatility is present, there's badness, and there's badness in the brain. There's badness for weaning and getting off. There's badness for renal failure. And obviously, for when venous congestion builds up, it starts at the IVC and it kind of spreads south from there. And when pulsatility gets transmitted the further and further away from there, it's telling you that the whole venous system is under tension. And like we saw earlier, most of the data that's available tells us that organs don't like high venous pressures. So we wanted to put this in context along with the IVC and other venous Doppler indices to make it a bit more robust, to avoid some false positives. And so we came up with the VExUS Score, which is a composite score of the IVC. So essentially it starts when the IVC is distended, large. And then the more there are abnormalities found in hepatic venous flow, in portal venous flow, and intrarenal venous flow, the higher your score is. And when we looked on a bunch of post-op cardiac patients, we found that there was a strong association with the development of renal failure, especially with the highest level of VExUS 3 level of venous congestion. And as well, it was also found to have more post-op delirium, to have a longer time to weaning and extubation, and all these things that essentially splenic congestion can possibly cause, because everything does end up having to get into the right atrium. So if right atrial pressures are high, things aren't necessarily going to go well. But a lot of patients don't have central lines in which we can measure this. So VExUS, and starting with your 2D examination of the IVC, can actually help us do this in patients who do not have any lines. And so we can assess, and you'll find, and I think we'll go through today, the different kind of scenarios in which you can find use for Doppler and point of care ultrasound assessment of the venous side in any patient. So hopefully this kind of brings us to think a little bit of organ perfusion after load, which I think is an important concept. And I can't wait to hear what the rest of the gang has to say. Thanks very much.
All right, thank you. That was fantastic. And I lost the agenda. I think, Katie, you're up next, right?
I think Abhilash is going to walk us through the waveforms.
Okay. Okay. We're going to save the questions until the end. But if you have questions, some people had sent questions to us in advance of this. If you have questions, go ahead and put them into the chat, and we'll go over those at the very end.
Okay. So let me start. So I'm Dr. Koratala, also known as NephroPOCUS, and thanks, Dr. Rolla, for nicely highlighting the badness of fluid overload and venous congestion. So once we start with the inferior vena cava, once we know that it is big and indicating increased right atrial pressures, you're going to look at these various abdominal veins and assess their Doppler flow to see how they are feeling the congestion. The first one is the hepatic vein, and this is how a hepatic vein looks like when you scan it from the lateral approach. So it's mostly blue because the blood is flowing away from the transducer, or in other words, it's flowing towards the heart, and it is good. And here is the pulse wave tracing on the right side of the screen. So you see predominantly 2 waves below the baseline, and 2 other small waves above the baseline. So below the baseline on spectral Doppler is away from the probe, or in this case, it's towards the heart. So these are the waveforms of a normal hepatic vein. So normally it's mainly blue on color with some redness. And the 2 predominant below the baseline waves are S and D. And below the baseline waves are also known as antigrade waves. So this terminology might confuse some people when you're reading a paper. So antigrade in this case is below the baseline, and retrograde is above the baseline. S is systole. So most of the blood flows into the heart during ventricular systole when the tricuspid annulus moves towards the apex and makes more room in the right atrium. That's the S wave. And towards the end of the systole, as the right atrial pressure increases because it's filling up, then you see a V wave. And finally, when the tricuspid valve opens during diastole, you see another big chunk of blood going into the heart, that is the D wave. And finally, at the end of diastole, when the atrium contracts, that's A wave. So you have these two small retrograde waves, A and B, and the major flow of the blood occurs during systole and diastole. These are S and D waves. When you have EKG, it makes it easier for you to identify the waveform. So S wave follows the QRS complex. And V wave can be above the baseline or also below the baseline sometimes. So that should not be confusing. So in this case, this is the S wave, and V wave is in between here. And this is the diastolic wave, and this one is the A wave. So A wave is the only retrograde wave here. And some people like to call it V wave, or some people just say like V wave is absent. So whatever you call it. So the importance is that when the V wave is above the baseline, if you do not have simultaneous EKG, it can get confusing to identify the waveforms. And here is how hepatic vein waveform changes with increasing right atrial pressure. So you can imagine this better when you imagine if there is a tricuspid regurgitation. And indeed, in congestive cases, most of the time, there is tricuspid regurgitation. So when there is tricuspid regurgitation during ventricular systole, there is a regurgitant jet coming back into the atrium. So that will reduce the amplitude of the S wave. So as the congestion increases, or as the regurgitation increases, or the resistance to flow increases, the S wave becomes smaller and smaller. Ultimately, S wave goes above the baseline or becomes retrograde from antegrade. And as the right atrial pressure increases further, the S wave fuses with rest of the retrograde waves, and you will just see one retrograde wave, which is fusion of all these waves, and just one antegrade wave is remaining, or only one wave is remaining below the baseline. That is the D wave, or the diastolic wave. And this is how it looks like when there is severe congestion, and when you see only one wave above the baseline and one wave below the baseline. That below the baseline wave is the D, or the diastolic wave. This is another example obtained from a patient with severe congestion. And this is to illustrate the importance of EKG. So when you have V wave above the baseline, you see multiple waves below the baseline, which is actually good. That means you know that majority of the blood flow is towards the heart. But at the same time, it's difficult to identify the waveform. So you can say this wave is D and this is S, which this makes it A, and this wave is V. Also, you can also label this as this one, where you can say this wave is S and this is D, and you can say the S is more than D, which is normal. And here in this case, S is lesser than D, indicating some congestion. You can only say that for sure when you have simultaneous EKG, when you see S wave after the QRS complex. So in this case, as you can see here, the amplitude of the S wave is lower than that of D, indicating some congestion. And having simultaneous EKG also helps when you have some arrhythmias. For example, in this case, this patient has only diastolic wave below the baseline. You can easily identify when you have EKG. And this is another tricky phenomena where S and D waves are fused, and without EKG, it's very difficult. This was one of my cases where I confused this with D only pattern below the baseline. But here you can see that this wave starts after the T wave in the EKG, and there is a blub here and ultimately extends after the QRS complex. So this is the fusion of this D and this S. So having EKG when possible helps, though it's not really a deal breaker, and you can still say majority of the blood is towards the heart or not. So the portal vein, Dr. Ola showed that like very pulsatile pattern. So this is how a normal portal vein looks like. This portal vein is also obtained from lateral approach, and it's usually red in color because the blood is flowing towards the transducer and into the liver. So normally portal vein is more or less continuous with a little bit phasicity corresponding to the A wave of the hepatic vein. And it does not have these typical S and D waves in normal scenario, because the liver sinusoids are preventing the transmission of the whole of CVP to the portal vein, so that it is protected from, not really protected from, it is shielded off from the whole of CVP. And that's why it's continuous. So normal portal vein is relatively continuous. And as the pressure increases, as the CVP starts to transmit it to the portal vein, it becomes more pulsatile. Normal pulsatility is said to be less than 30%, where you take highest and lowest points in one cardiac cycle and see what is the percentage variability. And as the RAP increases, the pulsatility increases further. And with further increases in RAP, you can have this flow reversal in the systole. So that's how portal vein looks like. And one caution is that in patients with cirrhosis, you can have pulsatile portal vein at baseline, even without elevation in right atrial pressure. That's most likely because of the local factors and portal hypertension. And if there is like severe portal hypertension, you can have complete reversal of portal flow. Instead of being red, the portal vein becomes blue. And as you see here, the tracing will appear below the baseline instead of above the baseline. You can see any of those. And hepatic vein also, the waveforms, the distinction between S and D waveforms will get blurred when somebody has cirrhosis. Same is the case with diffuse metastatic liver disease and stuff. So most likely due to local factors. And coming to the renal parenchymal vein or intrarenal vein, we stress the intrarenal part because we want to measure it in the interlobar vessels as much as possible, or arcuate vessels. Interlobar vessels usually have a better angle because parallel angle is better for the Doppler pickup. And we don't want to measure any bigger veins because they can have inherent pulsatility. And as you go inside the kidney is a closed space within the capsule. And as the venous pressure increases, you have some interstitial edema, and overall this closed system behaves like a cardiac tamponade. You can have renal tamponade from severe venous congestion. So we believe that intrarenal parts of these vessels reflect the changes in venous congestion better. And here is how you obtain a tracing. So you put that on interlobar vessels. So when I say vessels, you get both arterial and venous tracings usually because they are so small. And arterial tracing is above the baseline and venous tracing is below the baseline. That's just because blood is flowing towards the probe in the arteries and away from the probe in the veins. And the venous flow here is very continuous, same as that of portal vein. And as the right atrial pressure increases, the pulsatility of the renal vein increases, as you saw in the portal vein. So initially it's continuous, see only below the baseline. And with increases in right atrial pressure, you see this notching in between systole and diastole. That means it's becoming increasingly pulsatile. And eventually you see distinct S and D waves, like that of hepatic vein. That means you see one systolic wave and diastolic wave. The added advantage of having arterial tracing with the intrarenal vessels is that it acts like a built-in EKG. So you know this mountain is the arterial phase and this valley is the venous phase. So now you have a venous tracing here. Now you know it corresponds to systole, and the venous tracing here corresponds to diastole. So when you see two distinct S and D waves, that's increasing RAP, and with further increases in RAP, similar to that of hepatic vein, S wave reverses and you have only D wave or the diastolic wave remaining below the baseline. So to put all of these in one slide, so hepatic vein, as the right atrial pressure increases, normally the S wave amplitude is bigger than the D wave. And as the right atrial pressure increases, S wave becomes smaller and smaller, ultimately going above the baseline or becoming retrograde. And portal vein, normal pulsatility is less than 30%. And as the RAP increases, the portal vein pulsatility increases. Finally, there will be a flow reversal during the systole. And intrarenal vein is similar to that of portal vein, it's just below the baseline. And the pulsatility increases with increased RAP, resulting in two distinct S and D waves. And finally, only D wave remains below the baseline. So in the original paper that Dr. Rolla showed, they found that if you have severe patterns in two or more of these veins combined with a big IVC, the likelihood of having acute kidney injury is higher. So we have this one, like out of these three veins, if at least two of them show the severe pattern with a big IVC, that's not good. So that's all I got for now, and over to Dr. Viskar.
All right, thank you, Dr. Coratello. That was an excellent lecture. And Dr. Viskar, are you okay to start yours? Oh, I think you're muted.
Yes, I think.
All right, you're going to be talking.
I think we're good. Sorry, I just.
Clinical indications.
Are we good? Can you hear me?
Yep.
Great. Sorry, I just had to move to somewhere with slightly better Wi-Fi. Great. So thank you. I'm super pleased to be here with this awesome panel. So I'm going to talk, as said, a little bit about when this is all useful, and then share just a short case, courtesy of one of my fellows who I think is actually on the webinar. Hi, Terry. So in my mind, when I kind of try to conceptualize this, I generally think of sort of three groups or three situations where this is potentially useful. Two having some evidence behind them, and the third being kind of an extrapolation, but something that I've certainly done and I know people do. So the first is the post-cardiac surgery cohort. And I've included general ICU potentially, because there was a recent study from Rory Spiegel's group validating VExUS in that population. But obviously the work from Andre Janot and Dr. Rolla and his group were in this post-cardiac surgery population, basically using VExUS kind of on admission as a marker of adverse renal outcomes. So that's certainly one setting in which this is definitely applicable. The second population that I tend to think of is the heart failure population, obviously, and typically HFrEF and or pulmonary hypertension right heart failure, where you look for congestion as a marker of adverse cardiac or renal outcomes and or for help with sort of diagnosis of, acute on chronic kidney injury. And there's a decent amount of evidence there, both from the perspective of the individual waveforms, as well as recently a paper kind of looking at the VExUS score as a whole in that group. And then the third group, and as far as I'm aware, and I'm happy to be corrected on this, I don't think there's a lot of evidence here, but it makes sense physiologically, is kind of the resuscitation cohort, and sepsis is a common example, using these as an earlier stop point for giving fluids. So that is at least how I think of it. In my practice, I'm an internist. I work on the ward with complex medical patients. So I tend to use it very much in that second group, in the heart failure patients. And that's where I have found this really useful, is the heart failure patient who comes in with acute on chronic kidney injury, and they're impossible to examine. You can't see their JVP. You don't have accurate ins and outs on the floor. And so using this as another tool to help us distinguish pre-renal quote unquote injury from venous congestion, and giving everyone a bit more comfort and a bit more courage to, aggressively treat congestion and diurese these people, which can be hard because there is such an ingrained impulse, I find, in medicine still to give fluids to these people with kidney injuries. So that is where I have found it most useful. I have put this slide here, and I know we are all VExUS enthusiasts, obviously, on the panel. But I think it's important with everything in POCUS, and especially with something that is new and we are still learning about, like VExUS and solid organ Doppler for congestion, to remember that there are caveats to these interpretations, and there is still a lot of unknown that we will probably learn more about in future. So there are things that can affect your waveforms. Tricuspid regurgitation, obviously, will affect your hepatic portal and potentially your renal waveforms. Although you can argue that if you have congestion because of TR, then you still have congestion and should address that. As Abhilash mentioned, cirrhosis and portal hypertension can affect your waveforms. Intrinsic renal disease can affect your renal waveforms, as well as vascular pathology and cardiac disorders. So another reason why it's often helpful to do all of these waveforms, your hepatic, your portal, and your renal vessels, and interpret them together, because that can kind of mitigate some of these caveats. And then there are populations in whom this is still not studied, at least as far as I know, and we still don't know really how these maybe behave or how this may be useful. So transplant patients, end-stage renal disease, patients on dialysis, et cetera. So I think, and again, I'm happy to be corrected by other members of the panel, but I think there's still a lot to learn about this, which is exciting, and shouldn't stop us from using this now, but just good to know what some of the limitations may be. And then I'll just move on and share a short case as an example of where this was really useful in my practice. So this was a very typical patient on the medicine wards. So this was a 65-year-old woman, multimorbid, with a history of ischemic heart disease, heart failure, severe aortic stenosis, previous ovarian cancer, and then a few recent admissions. She had come in 3 months ago with ascites that was thought to be either heart failure or malignancy, and sort of discharged on fairly aggressive diuresis as well as heart failure treatment. And then came in kind of a month after that with an acute kidney injury that was believed to be pre-renal sort of ischemic ATN from over-diuresis from her heart failure, and was quite severe, and she needed dialysis for a couple of days. and eventually discharged home, and now comes in on this index admission with increasing abdominal girth, weight gain, and then this doubling of her creatinine. And despite this quite compelling history that sounds very much like fluid overload, everyone on the ward was really hesitant to diurese this woman, given her recent AKI that was so severe, given that she had this TAVI pending. No one wanted to mess that up with her kidneys. So this was an example of where VExUS was really useful in helping to confirm the fact that this was congestion causing this kidney injury in this case. So I won't show very much of her heart because that's not what this is about, but I just put this up to show you that she did have heart failure with severely reduced ejection fraction. And as you can appreciate from this apical 4-chamber view, also not a very good right ventricle with a dilated RV and impaired systolic function there. This is her IVC sort of fanning to a hepatic vein. So you can note what looks to be quite a plethoric IVC and quite a dilated plethoric hepatic vein there as well. I don't unfortunately have a short axis view, but we have been doing these routinely because I think it's a great way to corroborate your IVC. This is kind of the VExUS light. So if you find yourself without spectral Doppler, even color Doppler in a situation like this can be helpful, because we can see that there's that alternating red and blue flow, which would indicate a significant portion of reversal of blood flow. So S wave reversal, which we see here corroborated in our spectral Doppler tracing. So we have our D wave below the baseline, and then that big sort of fused ASV wave above the baseline there, in keeping with severe congestion as well as her known TR. This is her portal vein, again, just with color. And again here, even just with color, you get the sense that something is abnormal, as you can see a lack of continuous flow throughout the cardiac cycle, and you get a sense of pulsatility just from color alone. And we see that on spectral Doppler, there is not only pulsatility, but there's a little bit of reversal of flow below the baseline here. So her renal vessels were not obtainable. And I share this case anyways, because I think, at least in my practice, I find it's relatively common that I can't get great kidney tracings, intrarenal vein or artery tracings. And I think you can still get a lot of useful information from these waveforms without that. So these scans helped us feel confident that this woman had overload and ascites and AKI secondary to heart failure. So she was diuresed aggressively. She had a pigtail put in. And then we had a couple follow-up scans. This is her IVC on post-admission day 3, still looking very plethoric. This is her hepatic vein still looking like S wave reversal. And this is her portal vein still looking like flow reversal. So we pressed on with diuresis despite everyone kind of continuing being hesitant about diuresing this woman, although her creatinine was improving during this time. And this was on discharge. So this is now day 7 or 8. You can see that the IVC still looks very full. Her hepatic vein still looks to have S reversal. Her portal vein is pulsatile, although there's now no longer flow going below the baseline here. So not really a lot of change in her hepatic vein throughout this day. And I should mention with all this, clinically, by the time of discharge, she was on room air, had no ascites or edema, and her creatinine was back to baseline. So clinically much improved. And we did see some improvement in her portal vein tracing. So I think this brings up the interesting question of what is our endpoint with these patients? And should the goal be to diurese them all to VExUS 0? And I don't think that's a simple answer. And again, happy for others to discuss this, but I think especially in patients with complicated heart disease, in her case, heart failure with reduced ejection fraction and severe aortic stenosis, you have to balance those two difficult things and think about her forward cardiac output as well as her congestion. So this was kind of where we left it with her, and she ended up doing well and going on to get her TAVI. So that's it. That's all for me. Thank you, guys.
Thank you, Dr. Whisker. That was a great presentation. And next we have Dr. Roller, who's going to go over how to perform a VExUS exam. There's already been a few questions about that in the Q&A part, so I think people are excited to see this. Oh, I think you're muted.
All right, sorry about that. Thanks, Katie and Ablash, those are excellent presentations. I think I've already each sent you an email to steal some of your slides because I can't manage that kind of nice stuff. And probably this is going to be pretty scrappy too, but I'm going to try to show you guys how a basic VExUS scan is done. And to echo what Katie said, yeah, sometimes intrarenal can be very tough. Sometimes if you've got a dyspneic patient, it's just flat out impossible. Because you essentially, while you don't need a full screen perfect tracing, you need at least 2 good ones that you can feel confident that you've got what you want. So here's a quick overview. All right, so we're going to show you how to do a VExUS scan with the Kosmos. So here we go. Do it. We're starting in the subxiphoid area, going for the IVC. All right. So we're looking for the liver here. And there's our IVC. I can see that there's not much respiratory motion except at the tail end. If I go down a little bit further, we see that there's not a whole lot of respiratory motion. We see large hepatic veins, nicely dilated here. If I put Doppler through these hepatic veins, I can see that there's a lot of blue and a lot of red. We'll talk about that later. So I'll try to find. And like Ablash said, we should really have just a little, and you get your eye trained to it. It's pretty easy after a little while where you see a little flash of red and a bunch of blue, and you're okay. When you're seeing red, blue, I think it's been dubbed like the police siren sign. When you've got a lot of red and a lot of blue, that means that you're actually getting a lot of flow coming back towards you, which is in the right direction, and then points to a lot of congestion. One nice hepatic vein is fairly vertical, and I'm going to put Doppler through it, just where we see it, and here's our Doppler tracing. So we can see right there, we've got a little A, a positive S, and then the D wave. And sometimes it can get a little confusing. There can be artifacts, and be a little noise. My quick and dirty way to do it is to look what's above and look what's below. And you should have a whole lot more below than above. And if you don't, then there's probably something wrong and some congestion. You can see here that we've got a retrograde S wave. Through this a little bit. Just getting both arterial tracing. We see that we have a retrograde S wave up here and an antegrade D wave, and that is clear abnormal hepatic vein tracing. From there, where I'm going to go is I'm going to go laterally here, and I'm going to look for the portal vein. I've got to find a way because it's got a little bit of bandage here, but I'm looking for the portal vein. The portal vein's got white walls, referring to the bright hyperlucent walls of the portal system. The portal vein appearing, I can confirm by getting a tracing here. And right here, even in the color Doppler, we see the portal vein pulsatility. I'm going to add pulse Doppler on it. And we can see the pulsatile portal vein here. A little adjustment, we lost it a bit. It's a bit easier when you're not trying to direct and record. But I think we end up with a decent tracing. So here we are looking for the portal vein, the lateral aspect. In his case, he's got a dressing, so it makes it a little bit harder. We can see there the portal vein with the white walls. We can see the IVC in the distal field. And I put just color, and we can see here portal vein pulsatility. And we're going to put pulse Doppler right there. And we can see there the nice portal vein pulsatility, which is almost 100%. You can see it easily in the color that we've got nice portal vein pulsatility. this particular patient, the intrarenal Doppler is a little bit challenging. But the way we normally do it is to find the kidney. And incidentally, if we look up, you can see that he has a large pleural effusion for which we've put in a drain today. Drain that out. Now look for the kidney. But his kidney is not that easy to scan. I tried a little bit earlier. But normally in many patients, there's our kidney. We managed to get color flow. See some, we'll give it a try just in case we get lucky. Of course, with the respiratory variation, it can be a little bit hard to get. Not much luck on that end. All right, of course, the useful thing with doing point-of-care ultrasound is you can also look at what you might think of as the cause of the congestion in the first place. Here we're using the AI labeling to help those who are less familiar with the anatomy under ultrasound to look at a 4-chamber. We can see here that the patient's got a dilated RV, it's got an impaired RV contractility. We can see a thickened moderator band. And the LV is relatively well preserved. Both atria are very big, which points to the fact that it's probably an element of diastolic left-sided dysfunction, causing a whole chain of events down the system, leading to RV failure and splenic congestion, which that's often pop real quick. Back to the IVC there, we see again the IVC. One little neat trick also is you can just increase your depth and nicely see the pleural effusion that's there posterior to the liver. In this case, we're looking up higher into the chest using the probe angle like this. So that's a quick and dirty how to do it. And unfortunately, this particular patient that was yesterday or the day before, we didn't get good renal views, and we'll be sure to do another one with an easier patient and some clearer images. But I think, and at least in my practice, and I'm sure for Katie and Abhilash, when we're doing this simply for ourselves to make the diagnosis, to quantitate, it generally doesn't take more than 2 minutes tops to generate just about everything. And obviously a little more if you want more information, but just the VExUS Scan itself is usually really quick. And the quick and dirty is to start with just that IVC to get an idea if there is congestion and if it's worth pushing further to get more information as to the severity of this. I think that's kind of a quick little overview, and I think we'll welcome, headed back over to Robert for.
Okay. All right, thank you. That was a great demonstration there. Why don't we go ahead and we can try and answer some of these questions. Just looking at one from an anonymous attendee, I think would be an easy, is how do we apply this in the pediatric age group? And I don't think there is any literature on this. I don't know if anyone's ever done this on a pediatric patient. I've never. So I think that one's yet to be determined.
I haven't. I wonder, because I know there's data with a portal vein showing that you can have pulsatility in normal, like young, healthy, slim adults in particular. So I wonder if you would see more of that in normal pediatric patients. But I don't know. I don't do kids. I don't know anything about kids.
Okay. All right. I think Dr. Cortella, you had briefly talked about, Dr. Ackley has a question about how does Afib impact the interpretation of the hepatic vein waveform since the atrial contraction and relaxation is essentially lost?
Yeah, in atrial fibrillation, generally, you don't see A waves like that of EKG. EKG, you don't see P waves. So, and also the amplitude of the S wave tends to be lower at baseline because most of the atrial filling occurs during ventricular systole, at which time the atrium is relaxing. So as the atrial relaxation is erratic, you can have decreased amplitude of S wave at baseline. Those are the two key changes. And also sometimes you see fusion of S and D waves. That's also not uncommon with atrial fibrillation. Yeah.
Okay. And looks like he has a second part there about the hepatic vein waveforms. Do you guys have any preference, whether you want to use a lateral view or anterior, or just whatever works on that individual patient and gives you the best view?
Whatever you can get.
That's what I kind of figured would be the.
I usually start,
Lateral is easy.
I find I usually start subxiphoid because I'm usually subxiphoid, finishing looking at the heart, looking at the IVC. And so I'll check there to see if I get a good hepatic vein. But if I don't, I'm pretty quick to abandon and go lateral for my hepatic and portal.
Katie, is that one? I know you've, in your video that you have on your website, you've talked about how you will use the phased array to get your hepatic. Is that then when you switch over after that? Do you switch over to a curvilinear?
Yeah, and I mean, I think you can use either. I think the biggest advantage to using a phase for the hepatic is that you can do ECG gating if you have that capability. If you are not going to do that, then I think the resolution is a little bit better with a curvilinear. So then I'd maybe switch for all of them. But if you can get ECG gating, especially for the hepatic, as has come up many times on Twitter, as we've all been trying to decipher these waveforms that Abhilash posts, ECG gating can be super useful for the hepatic vein.
Okay. All right, thanks. Next question is, how does invasive positive pressure ventilation affect your VExUS exam?
I can take that if you want.
Sure.
So a little bit like Katie alluded to with the tricuspid regurg, the splenic organs don't give us a pass because there's another reason extraneous to sort of intravascular, venous pressure overload. The kidneys are not that bright. They don't care whether it's because of positive pressure, whether it's because of tricuspid regurg. If there's congestion, it's an organ venous afterload. And so you don't need to mitigate for that. You don't need to address for that. That can be your cause, because I think that's the most important thing to remember about the whole, VExUS and assessment of venous congestion. What it should tell the clinician is not like, oh, you're at, VExUS 3, you must get to VExUS 0. That's really not the way you should approach it. It should be an alarm, an alarm that says, hey, you have dangerously high levels of, venous afterload. Now it's, the ball's in our court as clinicians to figure out what to do with it. If it happens to be to drop your PEEP that was, unreasonably at 20 when you didn't really need it, that might be it. If it might be to add some milrinone to help your RV or an inhaled NO, that might be what you have to do. It might be Lasix. The rest has to go. It can't be a monosynaptic reflex to diurese everything that, that does have a high VExUS score. But all these other things, you have to remember that, the organs, they don't particularly care what the reason is for the congestion. If it's tension, pneumo, tamponade, it's going to affect them as a venous afterload, and that's the end of it.
Anyone else, or?
No, I think you said that very well. Agreed.
All right. There's two questions I think could tie in. One is from Dr. Kirkpatrick, wondering about variation in intra-abdominal pressure and how that's going to affect, I guess that could be the large volume ascites or the postoperative patients. And there's another one from an anonymous attendee, that they take care of a lot of abdominal surgery patients and find abdominal POCUS to be difficult. So they were looking for some alternatives, either femoral vein, which I know there's a paper by Denault and his colleagues, or IJ venous waveforms. Any?
So yeah, I mean, with increased intra-abdominal pressure, it is going to affect, several things. You do have to take that into account. So your IVC size might be artificially low to some degree. You might have a 15 millimeter IVC, but if it's because you've got 25 millimeters of mercury pressure around the IVC, then that's because of it. And that's going to have its own effect in terms of the organ perfusion. So you have to factor that in. And that becomes fairly complex. And I think you have to, it's really hard to make a hard rule about that. In terms of the femoral, which will also be affected by intra-abdominal pressure, Andre has put out a paper that shows that femoral vein pulsatility is also associated, just like we can imagine, with the rest of the splenic congestion with right-sided failure, etc. And I know that the jugular has also been looked at, and interestingly enough, John Emil Kenny, who's put together a carotid Doppler patch, I mean carotid and jugular simultaneous arterial and venous Doppler patch, has shown the same signs to pop up, and correlated it to it. It's unpublished data, but correlated to VExUS in a sense, or portal vein pulsatility, with changes in jugular venous waveforms as well.
All right. Great answer. All right, we have another question here from Dr. Morton about most machines don't have ECG gating capabilities. So why not simplify and just do portal vein and renal?
Hi, Tracy. Yeah, that's a good question. I think the hepatic vein is going to be the most sensitive to congestion. So if your portal vein is disrupted, you can argue there's little point in doing your hepatic vein because that is also going to be odd. I think the advantage of doing the hepatic vein is you may catch cases of abnormal hepatic tracings where the portal still looks okay, as it's basically a more sensitive marker being close to the heart. But as a quick and dirty, I would say you're not wrong, especially because the portal vein tends to be easier to scan and interpret. The renals I find harder. I find those are a bonus if I can get those, but the portal is probably the easiest if you were going to pick only one.
All right, thanks. Have another question from Dr. Velasco about, is there room for splenic vein Doppler and when do you utilize it?
Yeah, splenic vein Doppler actually, obviously it's directly going to connect into the.
I think we're losing you, or.
Is that better?
Yeah.
Hello. Yeah. I've used it a few times for fun, essentially, but it's real. Like Kitty was just saying, the intrarenals can be tough. The hepatic you can usually get, but I think the important thing to remember about the hepatics is that it's not really quantitative. So it's going to tell you a little bit more about the type of dysfunction to some degree. Like if you've got a clearly positive S, then you've got TR. You may see it disappear with management if it's a diuresis because you've just dilated you've stretched out your RV, you've got more TR, it comes down, but you may also not, so it's a little bit less quantitative than for the one that is the most quantitative is the portal vein. And of course the intrarenal, the one little caveat on the intrarenal is that sometimes the rhinosarca takes a little bit of time to clear. So even if you kind of decompress, you might see your portal vein tends to be the most real-time improvement, whereas sometimes their intrarenal lags a little bit behind. And again, sometimes because you can't get one or the other, that's why we chose to do that. But by all means, if you've got a big IVC and a pulsatile portal vein, and it's not a tall, thin patient on which it might be a false positive, it's pretty solid, And if you can't do the portal and you can do the splenic for whatever reason, that'll work too.
All right, thanks for that answer. Dr. Gonzalez asked, is it possible to predict diuretic resistance or the need for renal replacement therapy? I'm assuming based on a wave pattern. Any thoughts on that?
Abhilash?
Yeah, nephrology, you want to comment?
You can probably guess if oral diuretics would work, or if it's going to affect any oral bioavailability based on the portal vein congestion. But diuretic resistance as a whole, I think it depends on several things, how your distal tubule is, and if you have any tubular injury simultaneously going on. So I personally don't think waveforms themselves have a great role in predicting diuretic responsiveness.
Okay.
I don't think it was formally studied ever. So, yeah.
Okay. All right. Another question here, Dr. Gonzalez, is do you know if there's any correlation between VExUS and congestion biomarkers?
We actually have a study that we're planning to do, which will include that. I think there was a few that, that it wasn't sort of an unpublished data. There's some correlation, and empirically we've seen it, but I don't think that's formally out there yet. But to me, there's no reason why it shouldn't. The nice thing about VExUS on top of any biomarkers is that and POCUS, not just VExUS, but POCUS, is that you'll actually see the mechanism, whether it's right-sided or left-sided, et cetera, which we lack a lot of when we just look at an isolated BNP.
I didn't see it in the chat or in the questions, but thought I would ask, how often are you incorporating thoracic POCUS into these assessments? You're looking for B lines.
Most of the time, in general, right? I mean, it's a complete assessment of the hemodynamic circuit. So you want to assess the pump, pipes, and leaks simultaneously as much as possible. Okay.
Yeah, I agree.
Yeah, I mean, B lines is going to show you left-sided congestion, and VExUS is going to show you right-sided congestion. But yeah, you're going to look at everything.
Okay. All right. And here's a question from Dr. Turk. I guess this is in lieu of potentially ECG gating. Can you correlate systole with feeling the radial pulse with non-probe hand to assist in hepatic vein interpretation? I guess you could. Probably the more tachycardic they are, the more challenging that's going to be.
I think I've tried this, but I think I think it's technically difficult, and B, especially as you get farther away, obviously, from the heart, you wonder about the delay in feeling the radial pulse and seeing the waveform on your screen. So I don't know. I don't think that would be reliable.
Yeah, I would think you would have to go with carotid, if anything at all.
Yeah.
Sounds like something we did in medical school when you're listening and you're learning your S1 and S2s and you're feeling the pulse to try and figure out which one was which. And never seemed like that did work out very well. So I think ECG gating would be the preferred. Let's see, Dr. Dansel has a question. Would you say that hepatic vein is most sensitive and renal vein is most specific? That I think is going to be a tough one.
And I don't know about renal vein, if it's really that specific or not. Like one reason is, I mean, like when you think of CKD, it's like cirrhosis, right? Like you have fibrosis. So, and in CKD, you have more interstitial fibrosis also. So we don't know how much the local factors are affecting these. I think someone recently asked a question like, they get different waveforms when they scan right kidney versus the left kidney. I think the way to go is like multi-point like measurements, like we do for resistive indices. When you're being taught how to do resistive index, they ask you to do like upper, middle, and lower and take the average number. So similarly, when you're doing venous assessment, you should probably do a multi-point. And we really don't know how these turn out to be in patients with advanced CKD. I think that's a problem with the specificity of the renal veins themselves.
I think, Katie, this question is for you. In the case that was discussed with ovarian cancer and heart failure, the patient's portal vein waveform still showed mild congestion, but the creatinine went back to baseline. Has anyone noticed such changes in similar patients post-diuresis, and did the waveforms ever go back completely to normal, or is that their new baseline?
Yeah, so I think the question here is not like that this is normal now for this patient. I think the question is more, you will have some patients probably who have to live in a state of some congestion in order to balance their their preload and their cardiac output with their venous congestion. And I've had a few cases like this recently that our group has talked a lot about. But I think that's more the instance in this case, is that we recognize that there is a level of congestion there, but you're balancing that with other factors. And so, we didn't do this in this case, but it would maybe be useful to sort of serially do cardiac outputs using LVOT VTIs in this patient. and looking at other output measures, because especially in these patients with lots of other pathology going on, it can be a really thin line to walk to balance all that. So that's kind of my perspective, is that you won't get everyone to VExUS 0. Not to say that they don't have congestion anymore, but just they're going to live with some congestion.
All right.
Yeah, particularly with patients with pulmonary hypertension, you may never, and you probably shouldn't never try to get them down to a VExUS 0, because they may need a little bit more of their right-sided preload, so they may have to live with some congestion. It's also fairly impressive. Sometimes you have people with, fairly abnormal, and I don't know if it's because they have managed to get better renal lymphatics to clear their edema or what it is, but they can tolerate higher levels of venous congestion, oftentimes in the very, very chronic patients. I remember this lady I had who was like 99 years old, and she had such a huge RV. She had a VExUS 3, and she was totally fine, and her renal function was okay-ish, and she was okay. She'd adapted to it, and best leave that be rather than try to normalize these waveforms. So you always have to look at it in the whole clinical context, and it really, the last thing I would want to see is this becoming a monosynaptic, instead of the lactobolo reflex that we've seen, but like the VExUS late-6 reflex. It's got to be really put in clinical context.
Here's a question. We use systolic flow reversal as a marker of severe tricuspid regurg. In this setting, does this finding render this part of the VExUS exam less useful, or do you still incorporate that into the score in these patients?
I think Philippe addressed that, sort of to say, we know that TR will cause these waveforms to be abnormal, but it doesn't mean that the organ, that you get a pass for congestion just because there's TR there. So I think you're still seeing evidence of organ congestion, in this case from TR. But I think that you see that and you recognize that it's in keeping with their severe TR, but it doesn't negate the fact that there is congestion going on, and you may need to do something about it.
And from outpatient perspective, I see like cardiorenal patients in my nephrology clinic and follow them. I noticed that even though there is like chronic systolic reversal in the hepatic veins, renal and portal veins might still be amenable for improvement with your diuretic therapy. I noticed that if you think the patient is slightly on the volume overload side and there is significant pulsatility in the portal vein, you give metolazone or optimized diuretic therapy. Their portal vein improves while systolic reversal in the hepatic vein still remains. Similarly, just because there is systolic reversal in hepatic, renal doesn't need to have systolic reversal. Renal can have both S and D waves below the baseline. So that's what I observed, but it's a small group of patients though.
I know we're after 6 o'clock, but I think we can continue to go on if everyone's okay with that. For those that want to stay, I know some may have to leave, but this is being recorded, but we'll try and answer as many of these as possible here. Kevin had a question about what are your thoughts about VExUS for sepsis? I know it was briefly mentioned, but there's no current literature on this.
Yeah, I find oh, sorry, go ahead, Philippe.
No, go ahead, Kate, go ahead.
I was just gonna say, I don't think there's any data in this. I think it makes physiologic sense to use this as another, basically as another excuse, not that we need excuses not to give fluids. I feel like most of us here are probably restrictive with our fluids, but as another stop point to resuscitation in sepsis when people are trying to encourage you to give like a 7th or 8th liter or whatever insanity is happening, to kind of stop there and, pursue other strategies, pressors, etc. So that's kind of where I would see the role. But Philippe, you work in an ICU, you see severe sepsis more than I do. What do you think?
Yeah, I mean, definitely to me, it's a reverse point usually, and definitely to me, even a VExUS 1 of just a full IVC is a stop point in 90+% of cases. You always sometimes have to choose between the lesser evil depending on each case and each moment. But but that's generally it. And I think the data will, will end up, coming out. Dr. Glenn Hernandez is currently working on Andromeda 2 and looking at including VExUS in that, in the protocol there. I don't know how it's going to pan out, but they're looking at the concept of perfusion without congestion, which I think is, is definitely the way to go in resuscitation, because as I was alluding to earlier, congestion leads to microvascular, defects in perfusion. So I think it will have its role. Obviously now, I think honestly, fluid resuscitation is helter-skelter everywhere. There's not really good evidence in any direction. So I think when we have, physiological markers of badness, we should try to avoid getting there in the first place.
All right. Next question, Dr. Magri asked, is there any role for VExUS in fluid responsiveness as an isolated component without the other parts? I mean, I think taking out heart and lungs would, I would still like probably more than just VExUS alone. I don't know if anyone has different thoughts on that.
Yeah, in my mind, that's a different question. VExUS is looking at the back end and congestion, and fluid responsiveness is looking at, cardiac output and whether or not that will change. So I don't think so. I think in my mind, those two are separate things. Not to say you can't be considering the same things over, in a single patient over the course of a resuscitation, like in sepsis, but in my mind, I keep those two things separate.
Okay. All right.
Yeah,
next one.
absolutely agree with that. I think the VExUS is part of the assessment of volume tolerance, which in my mind is vastly more important a question than volume responsiveness, because by and large, unfortunately, what we've seen in the last decade or so, or 2 decades, since the Rivers early goal-directed therapy almost, and is the quest for volume responsiveness, and that's a vicious cycle. You can't get me started on this because we'll never finish. But it's kind of a vicious cycle to exterminate fluid responsiveness, which inevitably ends in venous congestion, and that's pushing someone up their Frank-Starling curve until they're on the flat part, which is only normally inhabited by end-stage CHF, end-stage renal disease patients. No one is healthy sitting in that flat part. And I think there's all the data in the world to support that. That is not a good place to be. But the hunt for fluid responsiveness, is fairly intense all over the world, and it ends up putting people there. So I think, to me, I often, tongue in cheek, I say I really don't care about volume responsiveness, and it's not entirely true, because I think it would be criminal to give fluid to someone who's not fluid responsive. But with a focus on volume tolerance, I think you never go flirting with the edges of volume intolerance or volume unresponsiveness. Sorry. And then so you rarely actually really have to concern yourself much with fluid responsiveness. But it's, much like, many approaches, it demands a complete flip in the way you think and approach hemodynamics.
Next question here from Dr. Powers. And I think this is really kind of a bane of our existence in the US, is the 30 cc per kg fluid bolus. I don't know, do you guys have to do that in Canada? You're not? Okay.
No, we're allowed to be actual clinicians.
Okay, so we robotically, if you don't give the 30 cc's per kg, usually you'll get a nasty gram from your hospital administrator saying you've now ruined the whole admission here. So the question is, it sounds like, if you have the medically complex patient who's septic, let's say has, significant heart failure, and now before you robotically give the 30 cc's per kg, what's the role for VExUS here in helping to guide that?
Yeah, I would hope that your hospital overlords would be happy with any clinical reasoning you use to defend your choice not to give that. Mm-hmm. But VExUS certainly would provide compelling evidence to say that further fluid would be dangerous and deleterious for this patient. So if you need further ammunition to support that decision, then I think that could certainly have a place there.
Yeah, if you're able to say that you're causing patient harm by doing doing some intervention, I think that definitely can counter argue whatever administrators have to say.
I think it does cause significant harm, that rule, because I think that you're just giving that fluid just to meet that criteria so you don't get dinged. And then on the back end, somebody in the ICU now is, doing renal replacement therapy, something else to try and counteract that, marker. Here's a question from Dr. Ackley. Which would you prefer? And I think, Philip, I think I know your answer on this one. Would you want a transduced CVP or a VExUS score if you had the option, and why?
I like to do both. I think the most powerful, tool is to mix. I like a PA catheter that gives me, if I'm doing a serious resus, PA catheter that gives me, pressures, pressure trends, changes with interventions. It's not always easy to get my PAPs, and I certainly can't stand there 72 hours in a row during resuscitation to constantly track my PAP on my TR jet, which is sometimes unfindable. So I think when you combine point of care ultrasound with a PA catheter, then you've got you're filling in the weaknesses of both sides, and you've got the most powerful assessment. Now, if you're going to ask me to choose between a CVP line and my trusty probe, I'll take the probe any day and twice on Sunday. But I think these things are complementary.
Okay. And Dr. Kasim has a question. Sometimes RV dysfunction is volume responsive. How can VExUS help to determine, for example, in an inferior wall MI? I'm assuming with RV involvement.
I think, again, then it's these questions of volume responsiveness versus volume tolerance, which are separate questions, and VExUS can help you address the volume tolerant aspect as one part of your evaluation. And then if you're really convinced that they're volume tolerant, then maybe you can look at other markers to help assess fluid responsiveness. But I would still be wary of giving a bunch of fluids to a patient with an RVMI who had markers of congestion on VExUS or on anything.
All right. Okay. And question here, say the patient's VExUS score is high, right-sided congestion. Besides diuretics, would you consider to start dobutamine, milrinone to reduce the pulmonary afterload, or even starting GTN if the BP allows to increase venous capacitance?
Yeah, absolutely. I think, again, like I was saying earlier, you can do any number of interventions. You have to figure out what the core problem is, what you have that's reversible in there, if any. And for sure, all those things are reasonable options, depending on the clinical scenario.
Okay. And Dr. Salinas just added one here. When patients have end-stage renal disease, heart failure, et cetera, you get away without using 30 cc per kg IV fluid resuscitation automatically. I agree that VExUS can also help in documenting volume intolerance. So not a question, but an answer, I think, to the one from Dr. Powers. Okay. And I don't know if it's true or not, but I've heard that rule is going away soon. So maybe we were going to be unshackled from that, but we can only hope. One last question I thought could end on, and it was an earlier one from Dr. Kumar, was about benefits of VExUS over a quick IVC examination. And particularly, I guess, people have asked, if the IVC is less than 2.1 and there is phasicity, is it worth doing a VExUS exam? Are there cases where it's still valuable?
I think typically, right, congestion starts with an IVC. I think I'm quoting Philippe recently on Twitter with that. But I think no, I think if the IVC, unless you have a really great reason why the IVC is going to be confounded, so intra-abdominal compartment syndrome or something similar, then with a small pulsatile IVC, you can stop. And then in my mind, you sort of progressively work farther down. If you see a congested IVC, then you go to the hepatic vein. If the hepatic vein is normal, then you stop. If the hepatic vein is abnormal, you go to the portals, and then to the renal. So I think that Progressing through the VExUS scans just adds more sensitivity, because the IVC obviously is sensitive, but not specific.
Right, when you add like combined VExUS score to just IVC alone or CVP of 12 millimeters mercury alone in the original study, it predicted the AKI better. And also, like, I think Dr. Kumar is one of the IM doctors. So I would say for our cardiorenal patients that we are admitting, like VExUS is a great tool to monitor the response to therapy. I think that's where it really comes into play. And obviously, like as Dr. Viskar said, if the IVC is big, you don't want to give fluids. That's top point right there. But if the patient is already overloaded and the organs are feeling the congestion, it's a great way to monitor your diuretic, the response to therapy. Yeah.
We have time for just one more. I think Dr. Megri put one in here real quick. What would you do in a septic shock patient who demonstrates that they're fluid responsive but has low volume tolerance based on VExUS? Would you go with fluids or pressors?
I would say pressors, but I'm the ward, so I typically don't have the luxury of giving pressors. I have to call my critical care colleagues usually to start that, but I mean, I think I have to say I can't think offhand of a scenario where I've had that where they look obviously fluid responsive. And again, we're not talking about that today, but like I guess by a passive leg raise, because that's it's a whole other ball of wax to talk about fluid responsiveness and how reliable that is. But yeah, I can't think of a lot of situations in which that would occur, but I think for me, the answer is usually less fluids if I can get away with it. So I would pick pressors.
And because the goal is not to exhaust the fluid responsiveness, right? That's one important thing, because I mean, the patient can be fluid responsive, and if you keep giving fluids till the patient is not responsive, and again, you have to work on the de-resuscitation protocol so hard. So
I think that became the push for a while, and the trend was to push the fluid responsiveness till you're at that peak on the Starling curve and they can't take one more drop. It's kind of like filling up your gas tank and getting those last little bits until it overflows. So and I think in emergency medicine we do that quite a bit, try and push that tank, push the tank to that part, but then obviously we're pushing into the bad side of venous congestion. So all right. Well, I think we've answered all the questions. I don't know, Carol, do you have the ending slide? So, I mean, want to thank the panelists, want to thank, Dr. Cortella, Dr. Rolla, Dr. Wiskar. I mean, this was phenomenal. And we also want to thank Echo News Kosmos, because they've agreed to do this as a series that we can then provide, additional webinars on this. So we just want to thank everyone. If you're not on Twitter, you should be on Twitter, and you should be following all the POCUS and the FOAMmed and the FOAMUS on there. And follow all of us on Twitter, and hope to see you guys out there on social media. So again, thanks to everyone for attending, and look forward to seeing you guys on future webinars. Anyone on the panel have anything else they want to say, or?
Thank you so much for hosting and moderating, Robert. That was great. I'm very happy to be part of this.
thank you.
All right. Bye, everyone.
Bye.